Okay, so as promised, for those who are on time, we want to be fair for everybody. So everyone that will join are most welcome. I'm Dr. Rafi from Tel Aviv. We have here Susana Palma from Spain. Say hello. Javier Rojano also from Spain.
Hi.
Nimrod Dickstein from Israel. Jignish Kotari from India, and Udo Winchmeyer from Germany. We are honored to show you today, to share with you our passion for the new project, Be Sure Aligner. Today, aligners are one of the most popular treatment option in the world. Many doctors are getting into aligners and they don't have enough knowledge and guidance and mentoring. So we will do everything in order to share with you our passion about clear aligners. So we'll show you a short video and then we will start.
I am Javier Rojano. I am an orthodontist working in Spain for more than 7 years with clear aligners.
I'm Udo Winsheimer from Germany, a patient Invisalign provider and diamond doctor.
I am Dr. Susana Palma, exclusive ortho in Spain. I am Invisalign Diamond 2 doctor.
I'm Dr. Javier Rojano from Tel Aviv, Israel. I'm diamond provider of Invisalign.
I'm Dr. Jignesh Kothari from India. We are top 1% diamond Invisalign providers in India.
I am Dr. Nimrod Dickstein and I'm an orthodontist from Israel. Since 2018, I'm serving as a clinical speaker for Align, sharing my knowledge and experience with the Invisalign system.
I'm really honored and delighted to invite you to join us in the free webinar of Be Sure Aligner, the new...
I just want to tell you that we have today 275 people with us. Some of them you see through the Zoom, some of them are directly in our website, Be Sure Aligners, in the event page. So you are all welcome, and we are happy to share with you our project. Today you will have tastes from everything that you will be able to see in the next month in Be Sure Aligner. So I'm delighted to pass the microphone to my friend Susana. Stage is yours.
Okay, Rafi, thank you very much.
Just one thing, all speakers, please, when somebody is speaking, turn on your videos off so they have only one video, all right?
Can you see my screen? Can you see my screen, Rafi?
Not yet,
No?
not yet.
Okay, let's see. Wait a minute. Just a second, please.
Just a minute now. Try now.
Okay. Okay. Here and here. Okay. I think. Okay. Can you see me now?
Yes, yes,
Okay.
yes, 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 yes.
Okay. Let's see. Okay. It's fine. Well. First of all, thank you very much, Rafi, just for allowing me just to be part of this great group of a speaker and great friends and great professional. I'm really proud to belong to this group. And of course, thank you all of you for being listening to us in our launching event. I am going to talk about digitalization with tabs. And well, just to introduce me just briefly, I am exclusive ortho in Spain. I got my postgraduate degree and my PhD at the University Complutense in 2002. And I got later on my postgraduate in lingual ortho. And many of the biomechanics that I'm going to show you in these two aligners, and you are going to see applied to the aligners technique, is something that I learned from lingual braces, and I have been using this same biomechanic with my patient of aligners. And also, as I told you in the video, I am Diamond 2 doctor provider. I work also as a professor of aligner system at Salamanca University. And also I am very proud just to belong to be a co-director of Aligner Academy International Advanced Program with my friends and colleague, Dr. Lozano. And well, I'm going to be talking about TADs and aligners. And why? Well, because many of the doctors who probably have seen me in any of the courses of Aligner Academy or an in-house course know that I love to be talking about the combination of TADs and aligners, because we can get what we cannot achieve with aligners sometimes, because we have some difficult cases. We can achieve it with combining the aligners and the screws, because the pushing effect of the aligners sometimes need a pulling effect of the screw that we can have just combining both biomechanic. And so we can use the TADs as an indirect anchorage, as you see in the photo above. We can use the TADs using in the tuberosity, or we can use the infrazygomatic TADs that Dr. Chris Chang is teaching in many occasions, or we can use indirect anchorage, just like the microscope that we see here, the interradicular one, just to hold the molar tight and to use it as an implant, just to have maximum anchorage and to increase the efficiency and the predictability of our cases. So these are the three main options that I normally combine in my patient with aligners. Sometimes I use the interradicular ones when are a small microscrew in between the roots, and for those cases I need to wait until the upper six achieve its final position when I'm correcting a class 2. And other times I use the infrazygomatic ones when I need the anchorage from the very beginning, because this kind of microscrew is going to allow the molar just to go through to distal and is not going to interfere with the microscrew. Especially sometimes in cases of class 2 division 2 that I need a lot of anchorage just to procline and to give a good torque in the anterior zone. And another times when I have a class 2 with tendency to open bite and I don't have the wisdom teeth, in many occasions I prefer just to use the TADs in the tuberosity, because in that way I can be distalizing at the same time that I'm intruding, and so I can create this anti-bite intrusion. I can create an anti-clockwise rotation of the mandible, and so I can get some more projection of the chin in these patients. So here would be the first case when we use an interradicular microscrew. Normally, as we are using these microscrews just to hold tight the molar, we don't need a big microscrew. With one small of 1.5 by 8 millimeters is going to be enough. We normally try to hold the first molar tight with this microscrew and to apply horizontal forces just to distalize 5 to 5 together. This will be the case. In this biomechanic, normally we distalize the second molar, then the first, then we just hold the first molar tight with a steel ligature to the microscrew, and we start distalizing 5 to 5 or 4 to 4 in a row, just holding all the anchorage in this first molar that is tight directly to the TADs. The second kind of microscrew that I frequently use in my practice is the infrazygomatic one. For example, in this photo that you see of a case of a class 2 division 2 that I just know that I'm going to need a lot of anchorage in the posterior zone just to procline this upper incisor and to provide a good torque from the very beginning. I decided just to start working with an infrazygomatic microscrew. These are the ones that are placed totally parallel to the root, and so it's not going to interfere with the movement of distalization. We can also use intra-elastic or inter-arch elastic just to be distalizing in a row 5 to 5 together, as you see in the photo. And the third possibility is when we are using the microscrew in the tuberosity, so in the place of the wisdom teeth. So in those cases, we need to have the wisdom teeth extracted at least 3 months before we start with the placement of this kind of microscrew in order not to have any problem with the bone of the tuberosity. So this is the position that we will be using when we decide just to use the tuberosity microscrew. I mean, what are the indications that I normally use just to treat my class 2 cases combining aligners and microscope? Well, first of all, when I have a patient, an adult patient with a full class 2 that has a wide upper arch, so because maybe he or she was using braces when he was young, and so now the upper arch is wide, so I know I'm not going to have many possibility of transversal compensation. So if I don't have this tool available just to assist me with the correction of the class 2, sometimes I am going to decide just to use that. Another indication for me is when I have a class 2 with proclination of the lower incisor. If I have proclined the lower incisor, or I have a very thin soft tissue in the lower incisor, I'm not going to be able to use class 2 elastic as anchorage just to correct my class 2. So in those cases, I also prefer just to combine my biomechanic using microscope. In class 2, division 2, as I was showing you before, you have to know that the more negative torque have the upper incisor at the beginning, the more anchorage we are going to need in the posterior zone. And for that very same reason, every time that we do not have enough posterior anchorage because we have missing teeth, or we have periodontal problems, is in those cases, and in full class 2 division that have a class 2, a full complete class 2 on one side and a class 1 on the other that are asymmetric adult patients, I'm going to use this microscope. And the two main options that I combine in my cases, one is to use the microscreen between 5R6 or 6-7. So we can use there the interradicular one or the infrazygomatic, as I saw you before, or using them in the maxillary tuberosity. And I love this the use of this last type of microscope, because with the microscope in the tuberosity, we are going to be able to achieve 3 movements in one with only one microscope. So we are going to be able just to provide expansion. If we place the microscope just following the labial surface of the upper teeth, we are going to be able just to make this expansion movement. We also can achieve some distalization. And as the microscopes are going to be placed higher in the occlusal plane than the occlusal plane, we also, at the same time that we are distalizing, we are creating this intrusion movement that is going to help us just to anterior rotate the mandible. So, but first thing first, we need to check if the bone in the tuberosity is good enough just to place our microscope. So normally I tend to distalize no more than 3 millimeters, because whenever I have a full class 2, sometimes I decide just to combine different ways of biomechanic, maybe some distalization in the upper or mesialization in the lower, or a progressive IPR in the upper, in the lower arch, or maybe some virtual jump if I have a very narrow arches that is a young adult patient, just to simulate the effect of the class 2 elastic. So the normal thing is that I do not distalize more than 3 millimeters in the upper arch. For that purpose, if I'm going to use the microscope in the tuberosity, I will try to place them at least 5 millimeters behind the distal surface of the second molar, because in that way, when I am just pulling with using the power change, I'm not going to drag the microscope or to sweep along the microscope too close to the molar, and this could be preventing the full distalization. So when we start the case, with this type of microscope, we just start changing the aligners every week when we are distalizing sequentially the 7 and the 6. And then one that we start moving from 5 to 5 or 4 to 4 in a row, that we are moving all the teeth at the same time. We are just using the microscope and the molar as anchorage. We are going to change the aligner every 10 days. So let's see a case of a young patient of 27 years old with a class 2 that I use microscope in the tuberosity. And at these first cases that I treated with this type of biomechanic, I made many mistakes. And so I want you to see it in order that you can prevent to make the same mistake that I made. So this young patient is, you can see, is a dolichofacial patient. Is a hyperdivergent skeletal class 2, a class 2 division 2, and maxillary compression. The patient has the lower facial height is increased. And she is a symmetric patient. We can see that the upper midline is centered. She was presenting a very narrow upper arch, so narrow smile with wide buccal corridor and negative torque of the premolar and the canine. And when we observe the mouth, we can see that positive things. Just to correct, this class 2 is, for example, that I have a very narrow arch, but the patient also has a very thin soft tissue. So I was just worried about how to correct this bilateral class 2 without just combining expansions, but also I need some more anchorage in the posterior zone just to provide a good torque in the upper incisor. And the patient was demanding to me a short treatment time and to shorten the treatment time. So that's why I decided just to make it my treatment more efficient, just to combine the microscrew with the aligners. We can see here the narrow upper and lower arch. And in the X-ray, she didn't have the wisdom teeth in the upper jaw. So I decided just to use this microscrew in the tuberosity. The patient was a hyperdivergent skeletal pattern. We can see that also she was presenting a class 2 and a lingual tipping of upper and lower incisor. So this is the clean check that I approve. I was distalizing first the 7, then the 6, and then once that I have achieved the class 1 in the molar, I was just moving 5 to 5 together in a row. Nowadays, if I will start this case again, for sure I will start proclining the upper incisor at the same time that I am distalizing the molar, because you all know that is a reciprocal movement that is done very efficiently when we combine it together. And also because I am using the microscrew in the tuberosity, so I have plenty of anchorage. In the lower arch, I was just using the expansion just to get enough space just to upright the lower incisor. And so in that way, I was increasing the overjet just to correct the class 2. The class 2 elastic was only used for night wear because I didn't have enough overjet, and I had made the mistake that I explained you before that I didn't ask for proclination during the distalization of the molar. So this is the IPR that we provide in order to increase the overjet from 3 to 3. And so we can see here that I was distalizing first the second molar, then the first molar. I was making the expansion in the upper arch at the same time that distalization, but I recommend you just to coordinate transversally the arches during the distalization. So in that case, you not start expanding so fast the lower arch if you're not expanding still the upper in order to avoid interference. So what I did is just this biomechanic, distalizing first the 7, then the 6, and once that we have achieved the final position in the 6, we do not activate the power change anymore, and we move 5 to 5 together in a row. So this is the expansion and simultaneous to the upper distalization. So we expand and distalize, changing the torque of this premolar, but asking for the technician to achieve a 0 torque, no more. And we are providing some lingual root torque also to the upper incisors. And check what happened to me. It was just activating too much the power change. And so as we are using direct anchorage, it's going to be more difficult just to control that we are going to have the same pace of movement than the aligners. So that's why when I checked that the molar was escaping completely from the aligner, I started just using the double cable mechanic that I learned with lingual braces, and I was using with lingual braces in cases of extractions, just to recover the molar to its normal place in the aligners. And so we finished the case. This is the final class 1 relationship. This is the final smile of the patient. So we can see how we have improved this wide buccal corridor that the patient was presenting at the very beginning. She has both midline center. We have made expansion of the arches, but not too much expansion, just the one that the patient was needing. And this is our goal of treatment. We achieved the goal of treatment that we have. So torque 0 in the lateral zone. We have a wide smile, both midline center, and a good torque, final torque of the upper incisor. So this is the initial and the final smile of the patient, and the initial and the final profile of our patient. So nowadays, I just recommend you just to use double cable mechanic. This is the one I normally use nowadays. Is just to start distalizing first the posterior segment using some bite ramp in the lingual surface of the upper canine, just to create some disocclusion in the posterior zone with an anterior attachment of anchorage in the incisor. So we move the posterior zone while we are proclining the upper incisor, and then we distalize the incisor. So we could see here how it would be a clean check using this biomechanic with microscrewing the tuberosity using the double cable mechanic. And so I don't know if you have any questions.
We'll do the question at the end.
Okay, perfect. So thank you very much for your attention. And I think my friend Udo can just take the microphone now.
You can stop sharing, Susanna.
Okay.
I just want to remind everyone that this is only a taste, and you will see in. Oh, Susanna, stop sharing, please.
Okay, here.
All right,
okay.
Good.
Okay.
Okay. And this is only for, in our project, we want to lead all our members step by step how to do all this, concept of clear aligner. So Udo, stage is yours now. Udo, unmute yourself, Udo.
Yes. Hello, everybody. So probably you can hear me now. Let me see. Okay, can you see my presentation now?
Yes.
You can see the first slide?
Yes.
Perfect. So thanks, dear colleagues, and being part of this launch event, and thank you, Rafi, for organization, everything. And it's a great team and a nice project. And with the first lecture of Susanna, I really see what's going on in modern orthodontics in the digital world and planning treatments with auxiliaries, with pads, and with aligner. Yeah, so fantastic work, Susanna. Thank you. And I would like to continue with a little bit, go more back to the basics. Why? Because at the end, to be successful, like Susanna showed in her clinical cases, we have to organize perfect clean checks, because perfect clean check is the base for the orthodontic treatment. And Susanna explained it to us how she managed it with anchorage, with pads. And so it's very important to figure out the main pillars to create effective clean checks, because at the end, everybody runs a big business, everybody runs a clinic, and so you have to be able to do it automatically. You have to know how to create your clean check in a fast and effective way. So my goal of the next minutes is to show you the main pillars and how our approach is when we want to check the clean check, to start with it and to modify it. So everybody knows of us treating patients with aligner that the clean check is one of a very important tool. That means the key of success. So without clean check, we won't be able to do these treatments. And when we work with clean check, we have to know that we communicate with different interfaces, which means it's not just a communication to one person. So we have to ask, who does the clean check? A couple of years ago, I think it was 7 or 8 years ago, I was in Costa Rica, because it was the treatment center of Invisalign all over the world. Now it changed a little bit. Every country has its treat team. For example, in Germany, Austria, and Switzerland, it's in Cologne, where I'm at the moment. And so Susanna has her treatment team in Spain. So in different countries, it's expanding, and means the reason is that we need more focused change of clean check. And so the question is, who does it? It's not only Michael, who was my digital dental technician, and nowadays there are educated CAD designer who do the ClinCheck. It's also the software. So means the software does a lot of work. They work with algorithm, they work with AI, which means artificial intelligence. And we need to know some basics about it. And of course, who does the ClinCheck too? It's the orthodontist. So speaking about this interfaces, we have to know how and why and how we will communicate. So which tools we can use to be effective with the ClinCheck. It's very important to know that we have different tools. And a lot of people, when I do my congresses, my educations, and my lectures, I realize that a lot of people forget the clinical preference, because the global clinical preference is the base, which means you use it for every case, for all the treatments. So you always should have a look to your clinical preferences, and especially when you're on the learning curve, you should adjust it to your personal situation. Where do you find it? Don't forget it when you go to the IDS. You see here, sorry, it's about in German language, but you see here your clinical personal preferences. And when you go there, you have to figure out different points. The clinical preference gives you your personal setup, your settings you want to get. In general, there are some general settings, but there are also some special instruction. And I want to figure out one instruction of it. For example, I learned a lot during the last few years. Sorry about that I didn't introduce myself. I will do it perhaps later on in the next lecture, of course. So one point was, for example, point 5. Why point 5? Because I learned when the patient bites on the aligner, you have an upper aligner, thickness of 0.75 millimeter. You have a lower aligner, thickness of 0.75 millimeter. In addition, it's 1.5 millimeter. In orthodontics, in medicine dentistry, it's an elephant. It's a really big thickness. That means when the patient is grinding on it, working on it with his muscle, independence of his habits, we will always have a little kind of intrusion posterior. What happens? We automatically get a Christiansche phenomena, which means a kind of auto-rotation. That means I learned, I was wondering always, because at the end of my treatment, I had a nice alignment of the arch, nice aesthetic, but the patient has always anterior pre-contact cause of this fact, cause of this auto-rotation, which means I brought this important information because I learned in my learning curve that point 5, please perform, dear technician, it means for all my patients, please perform overjet without any anterior contact, because the software and the CAD designer and the digital technician, they always do a little anterior contact and also posterior contact, everywhere balanced contact. But I say in my cases, no anterior contact, including the upper canines at all. And since then, I don't have at the end of the treatment anterior pre-contact, which is very important for the outcome and for the stability of your cases. So speaking about the clinical preferences, when you start a new case, you start with a prescription. You did it already. At the end, it's very simple. You go point for point through your prescription. You take your diagnostic, which is the base for everything, for the treatment plan, and you transform it in your prescription. But it's not only the general prescription, you also have a special prescription. What does it mean? You start with your case. It doesn't matter if it's Invisalign Express, if it's Invisalign Lite, it's comprehensive for teenagers, for adults, or it's Invisalign First. You start with the case, sorry again, because of the German language, but then at the end of your instructions, you have your special instruction when you start a new case. You have to communicate with your technician that he knows exactly, beside your special prescription, or your special instruction and prescription. Like here, you see different point, and it's very important that you provide it to your technician in a structured way, which means upper first point, second point, third point, lower first point, second point, third point, and perhaps also with inclusion. So you have to be precise to be structured with no acronyms, professional in a way that they can provide you the perfect clean check, perhaps even at the first part. There's an example. Use, for example, also preferences. So as a reference point, for example, lower arch, the technician doesn't know what to do. I give him the frame. The frame means lower front, no further proclination. Then, for example, then 3-1. And if there's still crowding, solve it with IPR. He knows exactly what's going on, what he has to do, because we have a diagnostic and we have to transfer it to the digital software, but we have to communicate once with the technician and on the other side with the software. This is for an example for my first prescription or special instruction when I did it in the upper. Sequential sterilization, distal rotation, expansion without any amount, even in my clinical preference. I said lateral extraction of more than 2 millimeters. If I need more, then I will specify it in my special instructions. So different points, which I use not only in the upper, also of course in the lower. Structured means first, second, third, and then you get very effective and very professional your first clean check, which you can use and modify. That means you have to communicate with the CAD designer with your comments, and a very important tool since 2 years since we have the CleanCheck Pro, that we can use the 3D tool, a perfect option. But I always recommend, it's my recommendation, start with the general prescription, start with the comments of the CAD designer structured, and then when you modify, then start with a 3D tool. And so step by step, you get your CleanCheck in a professional way. You can review it, you can modify it. For example, then when you get your first CleanCheck, like Susanna told, for example, when you distalize in a special way with pads, you have to check the staging. Perhaps they use the best protocol for staging. Perhaps you want to modify it. So you have to check the movement protocols, the staging, that you get it in your way you want to get it. Or, very important point too, the artificial intelligence and the algorithm of the software moves all the teeth. Even it's not necessary to move. Sometimes we have wisdom teeth, second molars, first molar, sometimes implants. You always have to be precise not to move this tooth. And when you realize, when you want to modify the CleanCheck, that it's not necessary to move the tooth, just go in the 3D tool and make it unmovable. And then in the superposition tool, you will see it like here, no movement at the second and first molar, which helps a lot for your anchorage, because we will learn it in this project to create anchorage. Susanna spoke about TADs. I will speak about different CleanChecks to create the virtual anchorage and the hybrid anchorage, which is a very important way in the aligner therapy. So use a 3D tool to do details. Always have an overview about the movements of the teeth in the 3 dimensions. You can use all the 3D tools to change, to modify the movements. You can use the cutouts, your attachments, change the attachment in different ways. That means the software provides the optimized attachments. Sometimes you have to change them in the conventional to get more anchorage. We have to discuss about it in our project. So to summarize, the first pillars when you want to create a nice, perfect, and an effective CleanCheck, don't forget the clinical preferences. Always have a free view and check it. Then use the prescription, the general one, and then specify it with the special instructions. Communicate with the CAD designer with your comments. Also read his comments and use the 3D tool to be very efficiency, because the goal should be, even it's a complex case, to do only 1-2 modifications to be precise with your CleanCheck to work clinically perfectly. So I hope I could give you an overview and the pillars for to create an effective CleanCheck. And now we can continue with my friend Jignesh, and Rafi will continue and moderate it. So thank you for your attention, and go back to the studio to Tel Aviv.
Amazing lecture, Udo, as always. Udo runs programs to teach clear aligner, master aligner case courses for many years, and we are honored to have you with us. Now, the next speaker, Jignesh, is probably, like me and Susanna, an old lingual user that in the last 2 years shifted, I don't know if all his work, but a lot of his work shifted to clear aligners. And you have to understand, our passion to clear aligner because it works. And we know that it can work in your hand as well. And this is why we created this project. So Jignesh, stage is yours.
Thank you, Rafi. And I'm going to start sharing my screen. Yeah, you can see my slide now. Perfect. So thank you. It's a great platform. We've all like-minded people have come together to actually create this platform where we can educate and share our knowledge, and of course learn from each other as we all grow in this field of aligners. So a little bit about me for the people who wouldn't know me. I'm basically from India, and my journey has been, as Rafi said, a predominantly lingual orthodontic practice for many years. And last 5 to 6 years, I have started to do Invisalign, and I've seen a lot of change and difference in my practice with aligners. And I think that's the future where things are headed with a complete digital practice now. Invisalign has a lot of levels. We've all of us here at the panel have crossed the level of the diamond providers, and that's basically just shows our experience in this field, and which is what we want to share with all of y'all. And most of us are now diamond plus, and I've got around 5 cases even in the Invisalign Global Gallery from the Indian continent, and it's fulfilling. It's a great tool to have in your practice, and I think everybody wants to learn more about aligners, which is why we are here. More than 200 to 250 people listening to us tonight for this launch event, which is great. And backing it right from Susanna and Udo, who are like excellent speakers. They run their own wonderful programs on aligners, and I'm just taking that bait forward today. So my 10-minute presentation here is basically on overtreatments and overcorrections. Before I get into this, I want to just address a few basic principles on how aligners work, because it's a very different thought process when we look at aligners and when you look at fixed braces and or even lingual orthodontics. So when you look at aligners, the concept is about push, right? So you need to look at the entire plan needs to be looked from a different purview. Instead of pulling teeth, we are actually pushing them into space, and that's how aligners actually work. So of course, it's not that big a push, but it's definitely a push. So when you push teeth, your entire perception about the plan actually changes from fixed braces. Aligners also have a versatility in terms of they can move teeth simultaneously. You can move them, you can torque them, rotate them, align them. All of this can be planned in your treatment plan, and it can be done simultaneously. So the efficiency is much more. But of course, we do not forget our basic principles of anchorage, even when we apply them to a plastic and see how a plastic can actually move teeth. So there's going to be an action, there's going to be a reaction, and we need to understand that for us to actually plan our ClinchX well, and which is where the whole focus of aligner therapy actually is. Now, just to put a simple question across, what is a ClinchX? What do you see a ClinchX as? When a ClinchX comes back to you, you open it up, you have a view in front of you, but truly it is a graphic representation of forces which are being applied to the teeth and not just simple animation. So the moment you start looking at a clean check in terms of forces that the plastic is going to apply to a tooth to actually move it in space, that's when the whole concept of the clean check is going to change. And that's when you're going to start applying your mechanics, your biomechanics, to actually understand whether this is going to really work in the patient's mouth, and is this the way the plastic will actually move your teeth. Another basic concept about aligners is teeth need space to move. So whenever you look at a clean check and you see that you do not have space for the teeth to move, you're going to be in trouble. So always make sure that you have enough space when you're pushing a tooth around with the plastic. And remember, aligners work within a perimeter. So you need to work within that perimeter to actually move your teeth around. And another important concept, which I'm here to talk about, is over-engineering your clean checks. And this is a must for us to understand to get a good clinical outcome, and a clinical outcome which we want as orthodontists, as dentists, to have the same finesse as you would have with a fixed brace appliance. So the two concepts are little subtly different from each other. One is called over-treatment. The other is called over-correction. Now, I'm going to highlight these two starkly different aspects to you today. Overcorrection. What is overcorrection? It refers to setting up individual tooth positions in the software plan that are beyond the desired clinical outcome. So it's related to individual tooth positions, right? This is anticipated when you have a difficult tooth position to begin with, right? You have a difference in the final position and an anticipated lag between the position in the mouth and on the aligner. Or if you see a potential of relapse, like a severely rotated tooth, right? So these are situations where you would bring about individual tooth positions and overcorrect them. This could be in terms of rotation. It could be labiolingual movement of your teeth. It could be just the tip of your teeth. It could be torque. So you're looking at an individual tooth. You're seeing whether that tooth is where you really want it at the end of treatment. You're predicting some kind of relapse or some kind of lag between the aligner and the realistic approach in the patient's mouth, and you're overcorrecting it in your plan. That is called overcorrection. Now, when can you do this and how do you do this? You basically do this in your 3D controls. It's very simple. We will teach you all of this in our master classes, how you can bring about overcorrection. It's a simple tool on the 3D controls now on your ClinCheck Pro 6.0 and whatever other softwares you might be using for your aligners. You need to bring about this kind of overcorrections in some kind of treatments. This is an overcorrection for the tip. So if you want to bring about an overcorrection in the root position of the tooth, you could bring it about with your 3D controls right in front of your ClinCheck plan. You don't need to now write it back to your technician. This is all in your hands with the new software, and it's very much doable for you to do it on your own. Same thing applies to the torque of the teeth. So if you want, and if you feel you're going to lose torque, or if you want a retrocline incisor to have adequate torque at the end of treatment, you can bring it about by overcorrection in the treatment plan itself. And this is what we call a difference between the clinical outcome and the lag between the aligner and the tooth. So you can ask for this in your overcorrection aligners in your plan, right? So you can write it down. If you're not savvy doing it on a 3D control, you can ask for it from the technician. You can also do this at the additional aligner stage. So now that you've had one bunch of aligners, you've understood which tooth actually doesn't have the potential or is not giving you the result as planned on the ClinCheck. You bring about overcorrection for that particular tooth or teeth in your additional aligner plan. So this is something you can plan at your additional aligner stage as well. The next concept is about over-treatment. Now, the first was overcorrection. This is over-treatment. This refers to setting up a final occlusion in the software plan, which is beyond the desired clinical outcome. So now you're looking at the whole segment of teeth, not an individual tooth. And you're making the final occlusion, which is much more than the desired outcome. When you do overcorrection or over-treatment, you do this when you have a malocclusion, which you anticipate is going to be different from the final occlusion that's built in the software. So when there is a difference between the final occlusion and the plan that you have done, that you can see in this slide, it's a complete deep bite case. This is the software plan, which is an ideal overbite. And this is what comes out in the patient's mouth with the same set of aligners. So obviously you can see there is a lag, right? So this needs over treatment. It needs over engineering your treatment plan so that you can receive and reach a plan which you desire actually in the patient's mouth. And this is the concept of over treatment. So over treatment is done to the entire position, the entire dentition, so that you can bring about the desired position at the end. So the difference may be due to a lag between tooth position intraorally and the aligner, could be variations in biologic response for the individual patient, and your biomechanical systems to actually drive that ClinCheck plan. Now, this can be done in three zones. It could be done in the vertical dimension, it could be done in the transverse, and it could be done in the anterior-posterior dimension. In the vertical, it's advisable when you have an open bite to actually treat your open bite to a 2 mm plus overbite. So when you finish, you actually have positive red spots in the anterior region, which is heavy anterior contacts. This is over engineering your plan so that you get the desired outcome. The same applies for open deep bites when it's a vertical problem, which is very severe to begin with. And a true deep bites are really tough cases to treat with aligners. You would want to over-engineer treatment plan to up to a 0 mm overbite to actually come to a normal overbite in the patient's mouth. So this is about finishing with heavy posterior occlusal contacts and a 0 mm to a minus 0.1 mm overbite in the anteriors to actually get the result you want in the patient's mouth. In the transverse dimension, maxillary arch expansion. When you look at aligners, when you look at a plastic from the center going towards the sevens, you can see the plastic becomes more and more flexible towards the end. And as it becomes more and more flexible, the efficiency is lost. So which is why you have to over-engineer your expansions as well. So you over-engineer it to an extent where you have your lingual cusp of the maxillary posterior teeth contacting the buccal cusp of the mandibular posterior teeth. So when you will look at your ClinCheck plan and you will look at your occlusal contacts, you will have a positive contacts which are red marks on these lingual cusps on the upper. This is over engineering your ClinCheck plan to actually get to a proper occlusion at the end. The new G8 feature, which we can discuss in detail again in our classes, is about giving your expansions more predictable, more bodily, with better attachments and better force mechanics. So it's smart force features along with your smart staging technology, which will give you a better bodily movement and a better scope of expansion in overtreatments for the transverse dimension. The last is the overtreatment in premolars, where in extraction cases, you could treat your maxillary and mandibular incisors torque in premolar extraction cases to counter the loss of torques. When you are teeth retracting, you will see that they start dumping inwards. So you want to counter that by giving adequate incisor torque. Now, note that this is built in the G6 protocol, but in sometimes you may not have G6 triggered in all your cases. Like a case here where you have G6 triggered on one side of the arch and on the other side, you do not have G6 triggered. So when you don't have G6 triggered on the other side, the default mechanism of G6 protocol do not apply for all these kinds of cases. So you will need to build in that extra torque in the incisors to actually bring about proper inclination towards the end of treatment, and you do not have retrocline incisors, you do not have posterior anterior premature contacts and posterior open bites. All of this can be discussed much more in detail in other classes of us, but this is to give you an overview of what you need to talk about and do in terms of overtreatment in extraction cases. Of course, your root inclinations. Now, this is something you can do in your 3D controls again, and you can do the same with an instruction to the technician. So either ways, if you're not savvy with 3D controls, you could write this to the technician. I want root inclinations to be set to tip towards rather than away from the extraction side. So it basically means that you want your roots to have tip towards the extraction side so that you are countering for the closure of space into the extraction side and the zone. So this is again over-treatment and overcorrection. So I hope I have been able to actually dissociate the two thoughts of what is the difference between over-treatments and overcorrections as far as the treatment for aligners is concerned. The take-home message for everyone here is very simple, that we need to think about over-engineering our ClinChecks. We need to think about how a plastic moves teeth. We need to think about the biomechanics. That does not change. We just need to apply the principles in the right way on the treatment plan, in the ClinCheck plan, on the software, so that that minimizes all your efforts on the chair side, and then you can have much more successful practices with aligners. So thank you everyone, and stay safe.
Thank you, Jignesh. As always, you are very, very didactic, and I like to be one of your students, whatever you teach. Thank you very much. And now we go for our next guest, Javier. Are you ready? Yes, Javier, you're with us. So I will let you present yourself.
Okay, thank you, Rafi. My name is Javier Rojano. I'm an orthodontist settled in Spain. It is a pleasure for me to be here amongst these great speakers and orthodontists. And they've been showing like so many ClinChecks, how we over-engineer the ClinChecks, how we combine auxiliary techniques like that, as Dr. Palma was saying. We was suggesting to focus on the clinical preferences at the very beginning, like the global preferences, and lately like preferences for every case. And the thing is that when we think about refinements, we think all the effort we have to do is on planning the ClinCheck, and this is true. But to be honest, after a few years working with aligners, to me it is clear that the shorter the refinements are, the happier I am. The less time, the less number of times my team has to bond and debond attachments, it is much better. So my presentation is going to be focused on how to shorten refinements, on how to reduce the number of refinements we do in our offices, not to plan them perfectly, because that's the rest of the team, at least today, but I'm going to focus on a few tips on how to reduce the number of sets of additional aligners. I guess that if you could answer to this question, it's like, do you want to order less sets of additional aligners? Everyone would say definitely yes. And this is because this is time consuming. It is having the patient a bit tired of the set of aligners. The treatment is getting a bit longer, doctor. I want it to be faster. They want to see the results. And so we do. But for this, apart from planning the perfect ClinCheck, apart from doing the perfect appointment and checkup to see everything is going okay, I think that whenever we have like some misfitting problem, whenever we see a discrepancy between the virtual and the clinical situation we are expecting, we should stop, which is something hard in daily life. We're fast, so we see this misfitting problem, and we tell our team to scan the patient to order additional aligners. And I think I'm going to try to show to you that in some cases, if we try to do some auxiliary techniques before scanning, the next set of aligners will be faster, or even we will be able to reduce or avoid that set of aligners. So if the answer is yes, if you want to reduce the complexity or the number of additional sets of aligners you are using with your patients, I think we should think on a few things. I think on IPR, I'm going to detail these topics. Think of buttons and elastics, on some occlusal adjustment before scanning the patient, and using precision pliers, as we were doing with brackets and wires. A good orthodontist needs pliers, even with aligners, especially, as I'm saying, if you want to reduce the number of movements. And those are the 4 tips I'm going to cover in this 10-minute presentation. So, Ignace, I loved your take-home message. I decided to put mine at the very beginning of the presentation. So the take-home message from my side will be: think before scanning for a refinement. It is even better than planning a perfect clean check, which is something we have to do, but thinking a little bit before can save us time, us and our teams. So if we think of IPR is something that we might think it's pretty simple, or dentists working with us might think it's pretty simple. But the fact is that if you check this article from a few months ago, we can see that the accuracy of IPR during clear aligner treatment is not really good. Check the boxes. The accuracy of IPR in the upper arch was estimated to be 45% for the upper arch and 37% for the lower arch. So usually we perform less IPR than we plan. This is a problem. We are performing less than 50% of the IPR we are planning on the virtual planning. So it is important to plan perfectly, but it's also important to execute. So we have to be, the more precise we can, the merrier we will be. But the thing is that at the very beginning of the treatment, it is easy somehow because teeth are still and bone is still around the teeth, but during the treatment, especially during refinements, the teeth are going to be moving because of the skeletal changes, the bone changes during treatment. And we know that if we don't measure properly and we don't perform and we underperform IPR, we might have problems like intrusion in this lower lateral incisor, in which we forgot completely about the IPR, or even some deleterious movements we want to avoid. See, for example, this case. In this case, we have this simple case. We wanted to rotate this lower left first premolar. Was planned some IPR. We underperformed the IPR. So at the end of the, not at the end, but during the treatment, we checked that there was a lack of fitting in this first premolar. We decided to rescan the patient. But as I was saying, usually we are performing less IPR because of the movement of the teeth, because we're not measuring it properly. I mean, it's not me or you, it's everyone. Usually it's what the literature is telling us. So in cases in which we have a Bolton discrepancy, especially for premolars, like in this case, it is advisable to check the discrepancy we have in between like second premolars, both in second and third quadrant, and perform the IPR before we scan the patient. Why? Because here, if you check the mesiodistal size of these two premolars, we see that we have to perform a 0.4 IPR in this tooth. Okay, you see the difference. It should be 0.4, but the thing is that we do it prior to the scanning the patient. So we have this situation in the patient's mouth, and we measure this, and this is 0.4. But when we measure this, due to the movement of the teeth, we find out that the clean check is saying 0.3. Luckily, as I have done it before, I can add some 0.1, and the mistake I am making in this occasion is less than doing in the prior set of aligners. So instead of scanning and working with only with a clean check, I suggest to perform IPR in cases in which we detect some bolt-on discrepancy on premolars, to perform this IPR prior to this, so we can see if we're making a mistake or not. This might be really simple, I know, but sometimes we don't think that this 0.1 mistake on the IPR, the lack of accuracy in this IPR, might lead to a problem in solving the rotation. So it is going to solve out some problems. Here you have another clean check. We have this extraction case in this patient, in which you can see at the very beginning a lack of overjet, excess of overbite, and a posterior open bite. So we plan a clean check to solve all these aspects. But the thing is that after this set of aligners, what we find is that we have reduced the bite, we have improved the overjet. I mean, there was a lack of overjet, and we changed and improved the anterior torque, but still, and this takes a lot of time, we hadn't been able to extrude buccal cusps of the molars. So we had this posterior open bite because we needed some extrusion. And sometimes we decide to, okay, we'll scan and we will solve it in the next set of aligners. It is much more advisable to have the patients for 2 weeks wearing elastics with no aligners on it. So we're going to fully extrude these buccal cusps. Oops, sorry. And we come to this situation. As you can see, in just 2 weeks, we have solved something that it would take a lot of aligners to solve, and a lot more time in just 2 weeks with no aligners on it. So we leave no contacts, no interferences, and we allow these premolars to extrude. Obviously, this clean check is going to be much easier than the one we had at the beginning, less number of aligners, and it's quite easy to solve this. In case we do not want to leave the patient without aligners, or the patient is reluctant to be like this, we can just cut the aligner distal and mesial to this area, and we'll have the patient wearing the elastics on this area to extrude these cusps and get to this ideal situation. Also, in cases like this, in which we have the Wilson curve affected by expansion, we might plan in this case, in this clean check, to flatten the split curve, but this is usually has to be followed together with like a huge movement of the roots to correct the torque. This is the ideal position, but we have to check and identify what is coming from the posterior open bite. In certain cases in which there is a skeletal discrepancy, we have to identify this, and we won't be able to straighten the root in this occasion because there is no bone, there is no more bone. So in these cases, what we know we have to do is make an occlusal adjustment to allow the posterior open bite to close. We have to identify these cases. Otherwise, if we don't check these situations, the skeletal availability to expand the root and to straighten the root, which is something we can do in this case because this is a camouflage, probably a patient that should have gone undergone orthodontic surgery. We have to make these occlusal adjustments to be able to solve that posterior open bite, but always prior to the additional set of aligners. Otherwise, it would take us a lot of time, and probably we won't be able to do it properly because this is not a matter of straightening the roots, but of drilling these palatal cusps. Okay, so we can check this with Anterior and scanning prior and after the occlusal adjustment to check the bite is closing, and the second, the next set of aligners will be much easier. But it is not just drilling or using baton and elastics. As I was saying, there are some auxiliary techniques we could be using to avoid more refinements. If you see this patient, we have the case almost ended, but we wanted to improve the relationship between the right canines of the patient, because of the torque of the 1.3 wasn't properly set. The thing is that we could order some additional aligners to solve this, but we decided not to do that. So what did we do? We checked the occlusion, and we saw there was an interference, probably because the tooth wasn't in the great position interaction. So we checked this, and we decided to drill and make some occlusal adjustment in this canine to allow some compression and improve the torque. Again, together with this, we decided to cut the aligner in the buccal segment, and with a plier, okay, you see the cut, and you see there's a space for the position to change the canine to the new position. And with a plier, we make an inset. So just with this, we have improved this canine relationship between the upper and the lower. And this, just with this, we don't have to do an additional set of aligners, but we just have to cut the aligner on the palatal segment and make an activation on the other side. So after drilling and making some occlusal adjustment, finally, we have a proper occlusion, and we avoided one set of aligners. So the movement is easy to achieve with no additional aligners, and it's saving time for us and our team. So 10 minutes later, I repeat the take-home message. Just think before scanning for a refinement, because it is even more important than planning a perfect clean check. And nothing else. Thanks for your attention, and also Rafi for the invitation to lecture today.
Thank you, Javier. I know I surprised you because you know it was my turn, but I thank you for popping in. I will give my lecture at the end of this session. So now, Nimrod, stage is yours. Okay, Javier, you can, yes, perfect.
Great. Can you see my screen?
Yes, perfect.
Excellent. Okay. So, thank you for inviting me. I enjoyed hearing all 4 lectures. And now I'm going to speak about a different aspect of aligner treatments. We have all used aligners to treat adults. We treat teens, but lately the feature of Invisalign First to treat younger children is also, for me, a great opportunity to achieve great result with much better efficiency than we used to. About me, I started using aligners 15 years ago. But at the beginning, I had no mentoring and no real way of learning. I started learning by treating and analyzing my cases and trying to hear different speakers speak about Invisalign and aligner treatment. I think it is very important in the early stages, but also later on, to get good guidance. It can improve us clinically. Today, most of my patients are treated by aligners, and I'm really happy to have this system in my clinic. So speaking about Invisalign First, usually I use Invisalign First for interceptive treatment of young children with mixed dentition. We all know as orthodontists that we have many flaws or disadvantages of using fixed appliances in young treatment with mixed dentition. Usually we don't bond all teeth, especially not the deciduous one. We have less control on the treatment with many emergencies and oral hygiene problems. These are all can be addressed and overcome by treating with aligners. And it's very important for us to plan the treatment correctly in order to get very efficient results. So today I want to share with you two cases. Both were treated by Invisalign first. And the first one is an 8.5-year-old boy. He wanted to straighten his teeth and correct his bite. So when he came to me, as we can see in his facial picture, we can see here a hint of the class 3 tendency, the projection of the chin. And we look in the mouth, we can see an anterior crossbite. And of course, the main issue is tooth number 31, which is moved out of the alveolar bone. We can see the recession, the gingival recession developing. And of course, the occlusal forces here will move this tooth further backly away from the bone and create a more severe problem. This is, for me, an interceptive treatment. We should not wait. We should address this problem as soon as we see the patient. So when we look at the panoramic X-ray, we can see is a young patient. The apices of the incisor are not closed yet. We can see the ceph. We can see the normal or even slightly proclined upper incisor, meaning that this correction should be done not by compensation of proclination of upper incisor. We should retract the lower ones to improve the crossbite. Luckily for us, it's a space dentition, so we have the space to retract the incisors. But in this case, the objectives would be, first of all, of course, to correct the crossbite and to cancel the functional shift. He had a 1 millimeter anterior functional shift. We want to create a positive overbite and overjet. I will state this later on. This is very important, achieving the overbite for the stability of the case. You want to extrude or help the eruption of the lateral incisors. And of course, we want to improve number 31, the inclination. We should not just tip it, the crown lingually, because it might even make the recession worse. We have to move the root in total into the bone. And of course, when we correct this crossbite and the functional shift, we allow for normal maxillary growth. And this, again, is very important for the patient. Looking at the clean check, when I planned this case, we can see the extrusion of the laterals, but more importantly, we can see the retraction of the lower incisor, utilizing the spaces we had at the beginning. I really like when I plan to use the superposition tool and watch the movement. You can see the staging. First, the first molar are expanded, then the deciduous one, and retraction, slight retraction of the upper incisor. They were proclined to begin with, leaving spaces for the canine. But look at the lower arch. This is very important. When you plan, you have to control the inclination of the lower incisors. So not just the crown, the root itself moved for a significant difference. You might say there would be an anchorage problem, and you are correct. We have to bear in mind that the molars won't stay in place. And when we look from the side, we can see the molars are staying in place, just a small expansion. But I remind you, we had a small functional shift forward, 1 millimeter. So actually, usually when I plan such a case, I would like to end with a bigger overjet. In this case, the overjet is very slight, but on the other hand, when we take the scan in the intraoral scanner, we took it with the functional shift forward. So when I look at this overjet, actually we have a larger overjet in the mouth. So even if I lose some anchorage, we can still achieve a nice occlusion and overjet. This is the initial. And this is how he came for me to my clinic. After 6 months, he was in a camp. We can see the labial frenum insertion, which is quite low. And actually, he went on a summer camp for the States. His parents were working in the American embassy here in Israel, and he lost his aligners. And he came to me after 1 month without aligners, and there was only a slight relapse of the upper median diastema due to the frenum. He was sent for a frenectomy, labial frenectomy, but it's very important. This is with no retention. And he left my clinic without a retention, because in this case, first of all, when you achieve a positive overbite and overjet, you have the best stability for this case, because the upper incisor hold the lower ones inside. And of course, if we look at the difference at the overjet of the patient and the overbite, and look at the lower incisors, look at the inclination before. Although such a significant retraction was done, we can see the root moved more than the crown did. And this is very important for the periodontal health. In this case, we can see the improvement in the profile. The chin projection has improved. Again, before and after. And look at the gingival recession. This is 1 month after treatment. Already the soft tissue has started to grow back on the tooth. And this is both in aesthetic aspect, but more than this in the health issue, in the periodontal state of this tooth, it's much, much better. So this is before. We can see the end result. And this took 6 months, 4 visits in my practice. I think this is the most efficient way using the Invisalign first. I couldn't even dream of achieving such a result with a fixed appliance, with such a great control in such a short time. So again, a very efficient way to treat young children. The second case, a 9.5-year-old girl referred to me from the pediatric dentist in order to correct her anterior crossbite. Again, we can see an interceptive treatment. We can see in this case, she has a severe crowding and rotation. Again, the main reason to intercept beside the aesthetic issue, because she was complaining about her smile, but we have also, again, a recession, which will become worse with time because of the traumatic occlusion. You can see the forces generated by the occlusion that moved the number 31 away from the bone. And we have to intercept this problem and correct it at this early stage. You can see the profile and the smile and the panoramic X-ray. She had a space maintainer. Of course, we had to remove it before scanning, and we gave an upper aligner just to hold it in place until we get the Invisalign aligners. Again, in this case, we would like to correct the anterior crossbite. Again, she had a 1 millimeter shift forward and to the left. Create a positive overjet and overbite, expand the arches, which is very important here. We have crowding and we want to resolve it, correct the midline, and let's look at the clean check. In this case, we didn't have the spaces in order to retract, but we used number 31 as a reference, and we didn't want to procline it, not even from the beginning. The technician was instructed not to move it, not to round trip the tooth, because it would even make the recession worse. The upper arch was expanded, you can see, and some proclination of the upper teeth. Proper choose of attachment. You have to choose the right attachment in order to get the control you want. Tipping such a tooth would create a torque issue and a vertical difference of the incisal edge. You have to control this tooth. It is very predictable. The expansion in the Invisalign first cases, again, proper choosing of the attachment for the control of the rotation and such a large anterior movement. Again, number 31 was a reference. It was retracted a little bit, and other incisor came to the same line, AP line, as this incisor. Okay, looking back at the case, we can see, again, the proper attachments to control the extrusive movement of the teeth, and here to control the rotation. We can see the black points, meaning these movements were considered by the software as a difficult movement to achieve. Of course, the bite jump is not an issue with the aligners, which helps us to open the bite during the treatment. Looking at the case again, this is how she started. This is the final result. Look at the change in the transverse, again, from here to here, creating positive overbite and overjet. We can see some resolution of the recession at the end of treatment. With time, it will get better because this was, I remind you, did not move buccally, only lingually. And now you can see how I planned the case. This is the digital treatment plan. And this is what we achieved in the mouth. There is maybe a slight rotation here, but for interceptive treatment that we don't need to get the perfect result by now, just correct this problem and achieve space for the canines, good occlusion, and better periodontal health. As you can see here, the planned treatment versus the real. You can see the midline was not planned to be corrected fully, again, because of the component left functional shift. So you can see in the mouth, the shift is even slightly lower than what was planned because of the cancellation of the functional shift. And you can see the difference in the smile. The patient was very, very pleased with the result. And now, of course, in this case, because of the rotation and the significant change in the position of the incisor, we have to continue the retention with the aligner at night. And you can see from another angle, again, the overbite is very important for the stability of the case. And again, we are talking about a 6-month, 4-visit treatment, which is very efficient and very easy for us, no emergencies, very easy for the patient. And I get wonderful cooperation from these patients. So looking again, the efficiency of Invisalign first in early treatments, the transverse dimension we can control even in crowded cases, the transverse dimension in mixed dentation in order to achieve the alignment of the teeth. And of course, we have to properly plan the clean check in order to get a great result and shorter treatment time. Thank you for your attention, and back to you, Rafi.
Thank you very much, Nimrod. And we are getting close to the end of this session. I can tell you that especially now during the COVID time, we have friends here. Jignesh, India is in lockdown, and I think Spain as well. So this platform will give you a very, very good solution to help with your clear aligner guidance and mentoring. So let's go to the last lecture. I'm Dr. Javier Rojano from Tel Aviv, Israel. I will speak about simulation and progress assessment. Those who do not know me, I don't think there are a lot of people who do not know me in this group, but I've edited 5 books in dentistry, some of them in lingual orthodontics. Nowadays, I do mainly clear aligners. I have 4 kids. This is my wife and my 4 kids, and this is my staff in the clinic. We are growing every day because of aligners. We have more and more work and a lot of efficiency in our clinic. And what we want is, and this is the main message of all this project, we want to have less clinic chair time and maximum control of our cases. So I wanted to concentrate in this lecture about prediction. And Udo already talked about how we can guide our technicians in order to have the best results from our cases. And Javier talked about the refinement. So what I want to show you that we have tools now to monitor what we are doing in our own clinic. So in this case, for example, where this patient came to me after 2 failures of orthodontic treatment and an open bite, which is, of course, is also for a very different aspect of orthodontic treatment, about stability and open bite. But he came to me with the cribs in order to block the tongue, and nevertheless, nothing happened. And you can see that this patient wants to know now in the chair time if I can perform for him a good result. So the simulation is not only for marketing, but mainly for patient education and for chairside planning, as you will see, and to check all the alternative options and implement our functional and aesthetic vision. I'm sorry, I have sound I want to mute everybody with your permission, because perfect. Okay, thank you. So, and of course, we want also to share, save, and send, as you will see in a minute. So when you do a chairside simulation, we actually want to be able to plan chairside. After we scan, we want to plan our treatment. And you have to remember that when you send your cases to the Align technician, he actually, the first step that he does is doing segmentation. And segmentation is to define every tooth alone. So he can move the tooth, buccal and lingual, and right and left, and up and down. So the Anterior that I'm using in my office, and nowadays Carestream has it, many scanners are putting it inside, that we can have an automatic segmentation. An automatic segmentation based on artificial intelligence let you do your simulation, your clean check in front of the patient. So you can see here how we actually go to the scan of this patient and perform a simulation. And the simulation is based, first of all, on the algorithm that is integrated in the scanner. And the algorithm has a lot of knowledge about what is the desired arch width, what is the desired overjet. And as Javier and Udo mentioned, there are many, many things that we know today after doing thousands of cases with clear aligners. We know today that the algorithm can give you one thing, but we want to do another thing. We know from our experience that we have to integrate some changes. So you can see here that after we do the simulation, we can put our vision, and our vision includes the function, include aesthetic, include stability. We know that some movements may be very good to do, may be very easy to do, but they are not stable. And also we want to have here more biomechanical knowledge that we know, like Susanna showed in her cases. Many times we know that if you do such a movement and a lot of distalization, we will need TADs. So, or we want to do more expansion, we have to integrate the biomechanic into our simulation. And of course, to use our experience that from time to time, we improve our simulation. And this is exactly where you put your input. And this is what we will try to teach you in our project in the Clean Check review session, how to implement your own vision on the case by doing all these changes in the simulation or later on in the Clean Check Pro. So you can implement any change that you want in tooth position, in rotation, in arch width. All the changes are very, very similar to the way you do it with the CleanCheck Pro. And when you finish your modification, we share our ideas. And as Udo said, showing nicely what happened with the technician in Mexico or in Europe or wherever, they want to know exactly what is our vision. So I share my ideas with all these 4 people: the patient, the dental team, my colleagues in the clinic, and interdisciplinary team, and the technician of Invisalign. So instead of writing all these instructions that usually I do is the same as Udo said in the general preference of my cases, I just write a sentence: please refer to Anterior simulation name version 1 and scan ID number in these instructions. And then the technician will be able to look at your vision and create a CleanCheck which is based on your simulation. Now, I hear a lot of comments about how accurate the simulation is. You have to understand that simulation is exactly like Waze. When you drive with Waze and Waze recommend you to go to a way which you don't know, which is not familiar, then what you do is not go automatically in that way, but at least you have to think why Waze is guiding you there. So what I do here is I try to see exactly why the algorithm gave me these specific attachments. These specific attachments has some reason, because when you do the extrusion here for the anterior teeth, you will have intrusion in the posterior teeth. And you will have, when you do expansion, you will have tilting of these molars. So the algorithm will give you an automatic optimized attachments with an angulation which is suitable for the movement that we want to achieve. So if you want to change a specific attachments, you have to exactly know why you are doing it. And this is the result after not more than 7 months, and you see the result. Of course, we will speak in our project also about the term that I call active retention, which is designed in order to have better retention and also a reaction to this intrusion tendency caused by the tongue. The second thing is the progress assessment, again, integrated in the Anterior and helping a lot of work with Invisalign, but we will support not only Invisalign doctors, but every clear aligner user, because the principles in clear aligners are the same for every technique and every manufacturer. So you can see here a case which obviously was, again, very difficult to decide if we want to do this case with extraction, with IPR, how much anchorage we need, how much stripping. So again, I use here simulation, which I will show. And we did some plan here. He is class 3. And we did some plan that includes a lot of stripping in the lower arch, which of course should be very, very precise and very careful in order to achieve all the movement that we want. So in this case, we had 32 aligners that were supposed to solve the case. And you can see that patient got to my office at aligner 25. And usually what I did in the past is look at the case, look how the aligner fit, and compare the clinical photo to the CleanCheck photo on that stage in aligner 25, upper and lower. And it looks, in a normal eye, it looks almost the same. But when you do the progress assessment software, you can see a lot of different colors. You can see here yellow and gray and purple, and each color code has a different meaning. Yellow means that the movement is not on track. usually around 10%. Gray means that there was no movement detected. And purple is probably the most thing that you have to notice, because in the purple means that the tooth moved in the opposite direction, which means usually you lost anchorage. And if you look at the table, we can see exactly what type of movement in this specific tooth did not happen. Maybe the buccal movement and the distalization and all the other movement happened, but the extrusion and mesialization did not happen properly. And in tooth 26, the buccal movement went on the other side, meaning that the tooth moved palatally. So, and the same for the lower arch. We analyze the table, we analyze the results, and then we have to decide what is the best thing to do now, to continue to aligner 32 as planned and then see if we will get the result. Maybe now to instruct the patient to be more days for each aligners, maybe to order additional aligners, maybe to check, as Javier showed, to check the IPR, maybe to use different biomechanics. And this connect me again to what Susanna started. Maybe this is the time to add TUDs, to have better anchorage, to add elastics, all the things that we talked today. And also I can do now another simulation showing the technician exactly what type of movements I want to do to finish this case and order new aligners according to the new simulation. So as you can see in that case, instead of moving from 25 to 32, I ordered another 13 aligners, which actually was another 6 aligners from the original plan, and finished the case. And when I finished the case, I did again a progress assessment. And then I saw now, as you will see, the upper, the lower, and now everything is totally green. So I thank you all for attending, and I invite all my partners to open their videos. All the participants, you can open your own videos, so we will be all together and share with you before the weekend. So if you want, you can open all your videos. And if you have any questions about, not about the cases, please, but about the project itself of B-Sure aligners, you are most invited to open your microphone and ask us.